Thank you very much. I must thank the organizing committee for giving me this opportunity to talk about the challenges in setting up an ABO incompatible transplant, logistics, cost, and who is the right candidate. These are my disclosures. ABO incompatible transplant has become an established alternative treatment in patients of chronic kidney disease and end-stage kidney disease as an alternative. And most studies have suggested that the outcomes in ABO incompatible transplant are reasonably comparable to ABO compatible transplants. Although, when you look at all the centers across the world and you look at the meta analysis, which have included all the trials, then the outcomes are inferior to ABO compatible transplant. And the main reason for the poor outcomes is the infections, because there is greater immunosuppression related to desensitization process which is involved in ABO incompatible transplant. The advantages of ABO incompatible transplant is that it increases the donor pool, and especially in Japan, say 30% of patients, because they don't have a good disease donor program. This is what is happening in our country as well, especially in the northern states where we don't have a reasonable disease donor program. Therefore, and we don't have a national swap program. Swap would definitely be a much better option than an ABO incompatible transplant. As I said, 3 to 5% of patients may develop severe acute antibody-mediated rejections, and these are unpredictable and they are usually catastrophic. The kidneys have to come out. So therefore, it's good to have a swap program, and this is a good forum to sort of initiate this national kind of a swap program where you can include the HLA incompatible transplants, which are difficult to be transplanted. So if you can get these patients who are highly sensitized and accept them into a swap program with a low HLA sensitization. Programs with ABO incompatible demand multidisciplinary coordination, cost planning, and rigorous protocols, and therefore the main aim of doing an ABO incompatible transplant and the successful is to have a safe desensitization process, a sustained graft survival, and an infection control in these patients. The problem is the variability in the natural anti-ABO antibody titers and their measurements methods. And the next talk is going to be on these measurements, but there is a variability, unfortunately. Whatever techniques are available currently, there could be a 1 to 3 log variation between various centers, and sometimes in the same center, the same patient might show you a different kind of variations, and that's an issue with ABO incompatible transplant. But this is something we will have to have better methods probably. We need to also organize for optimal desensitization protocol. It's good to be locally specific. Whatever you are good at doing, do that. If you haven't done immunoadsorption and all, then it may be better to do plasmapheresis in them, and plasmapheresis is reasonably successful in many of these patients. You will have to decide on the rituximab timing and the dose. That has been also varying, but for a particular center, it's good to establish a particular day of the giving 2 weeks, 3 weeks before the transplant, and then whether you use 100 milligram, 200 milligrams, or 500 milligram, which is what has been used in various centers. You need to look for monitoring for antibody rebound, and that seems to be a problem, and that might cause an antibody-mediated rejection. So you need to also balance immunosuppression versus infection. So these protocols need to be set in each center, and that's important. You need, obviously, a reliable, reproducible, and tighter measurement, as I said, but that's an issue. Availability of immunoadsorption columns, or you should have a capability of doing plasma exchange in these patients. And immunoadsorption columns are usually used in centers when the titers are higher, more than 512. At our center, we use immunoadsorption column, but if the titers are lower than that, then we use plasma exchange for cost effectiveness. High equipment and consumable costs are required. Training of transfusion and immunology staff would be required. Standardization of antibody assays. These are all what is needed. There is also a need for multidisciplinary coordination between nephrology, surgery, immunology, and transfusion medicine as well. So you must have all these departments coordinated to, then only you will have a successful ABO incompatible transplant. And as I said, that you need to have a standardized desensitization program, and a good follow-up and SOPs are extremely important to establish an ABO incompatible transplant. The infrastructure for close post-transplant monitoring, data management, and continuous audit of your system is extremely important to find out where you made mistakes, and those can be corrected. Cost of ABO compatible transplant is much higher than the ABO compatible transplant because of the rituximab intravenous IG, which is used after plasmapheresis in many centers. And then if you need immunoadsorption columns, then these are fairly expensive. There is limited insurance coverage in our patients and reimbursement challenges, and many times the insurance may not pay for the high cost of the ABO compatible transplant. So there may be a prolonged hospitalization, and that again increases the cost. So these cost constraints must be discussed with the patients before you undertake ABO incompatible transplants. Obviously, there are regulatory and ethical considerations which you need, which is fortunately standardized currently in India: institutional ethics or transplant authority approval, explicit informed consent. I think this is extremely important. All the pros and cons of an ABO incompatible transplant need to be documented and need to be talked about in these patients. Transparent communication regarding outcomes and alternatives are extremely important for not creating a havoc in the post-transplant period if there is a rejection, if this has not been talked about. So there is obviously the outcomes and the experience gaps are there, and therefore there is a learning curve. Although if you read Montgomery's paper, first paper across 790 transplants across the US in 2011, he concluded that there wasn't any difference between centers which were doing small numbers of ABO incompatible transplant compared to the others. But there is probably some curve. What's the cost at our center? Usual ABO compatible transplant costs around 9 lakhs with the induction. Whereas in the ABO incompatible transplant, you will have to include the cost of plasma exchanges, immunoadsorption columns, cost of desensitization or eculizumab if you need eculizumab. Then this may come to around 8 to 15 lakhs, 5 to 15 lakhs extra. It could vary depending on the antibody titer also. Now, who is the right candidate for ABO incompatible transplant? ABO compatible or paired kidney donation would be preferred over ABO incompatible transplant. And if patient doesn't have an ABO compatible donor and he is not for the waiting list for disease donor transplant, then I think if there is an ABO incompatible donor available and the titers are, although high titers were considered to be bad, but I think in our experience, I think titers don't matter. Probably it's the cost of desensitization of high titers that is important. If you have, as I said earlier, if you have an HLA incompatible donor, you have antibodies against anti-HLA, then obviously ABO compatible would be a better donor. And if you can bring down the anti-HLA incompatibility by getting an ABO incompatible donor but with less anti-HLA antibody, then you might be better off. But combining ABO incompatible and an anti-HLA antibody is a high risk kind of, and I would avoid that. So with an ABO incompatible, you should have a better HLA match. That would be. Usually titers, as I said, 120, 256, 128, 512 are equal, but I think high titers are also okay. Titers may not be important, and whereas rebound of titers probably may be more important. Who is not a right candidate for ABO incompatible? Avoid ABO incompatible and HLA incompatible transplants, cross-match positives. Very low anti-HLA antibodies, as was said by Narayan, with flow cross-match is negative, then they may be acceptable still. Marginal recipients. So for ABO incompatible, we usually accept many donors, but for ABO incompatible, don't accept marginal recipients. Elderly recipients also may not be the best. Do it in younger patients, avoid marginal donors. And someone with poor finances would not be a good kind of. So, ladies and gentlemen, let me conclude. Key challenges in ABO incompatible transplant program requires considerations for collaborative coordination amongst various stakeholders. You require a good lab, immunological lab, tighter variability, antibody-mediated rejections and infections are concerns. You need also standardization and access to columns or to plasma exchange. You need a coordination data system. This involves high cost reimbursement. And there is obviously a training and infection prevention control required in these patients. Thank you very much for your patient hearing.